that's registered in. Can you hear me?
Yes.
With the mask? My name is Paulette Zielinski. I'm president of Arthritis West Island Self-Help Association. So I'm pleased to welcome you tonight. Glad to see a few of you have been able to brave the cold weather. So Dr. Hudson will be doing her presentation, and it will also be recorded, I'm assuming. And if there's any questions, it's after the presentation that we have the question and answer period. But I also want to mention that we will be having our AGM in this location on June 13th. And our guest speaker will be Dr. Michael Starr. And the subject of his presentation will be the holistic of arthritis, treating the whole patient. The doors will open at 6:30 on the 13th. And if you wish to be present, you'll just have to call the office or email the office. And I'm assuming that you'll have our address. So it's with great pleasure that I'm going to ask our board member Leah to introduce Dr. Hudson.
I don't know if I need a microphone.
No?
Can you hear me? I have a pretty loud voice. Yeah, I don't like to hold the microphone. Just wanted to let you know a little bit about Dr. Hudson's background. Dr. Hudson's a rheumatologist at the Jewish General Hospital and an associate professor and member of the Division of Experimental Medicine in the Department of Medicine at McGill. She pursues research in rheumatic diseases, in particularly lung disease, in scleroderma, myositis, and rheumatoid arthritis. Dr. Hudson is also a practicing physician and has cared for many patients with rheumatic diseases affecting lungs. And I have something I would like you to explain to them before you start your presentation. Dr. Hudson is co-director immunity of the McGill Interdisciplinary Initiative in Infection and Immunity, which provided $1 million to the FibreNet project to study the mechanisms of lung fibrosis in rheumatic disease. And I would like her to slightly explain this a bit. And the other thing that I must add, that Dr. Hudson has been really supportive of AWISH over the years, and something we're really grateful for. She's been a great mentor and a great supporter of our organization. So I present to you Dr. Marie Hudson.
So good evening. I'm just going to put this here. So it's a pleasure to be back. I have been here. For those of you who have known me for a long time, my oldest son turned 18 in January. I remember, I think the first time I presented here, I was pregnant with this child. So that was probably my first presentation. He's 18. And the second one, and I remember presenting pregnant a second time, is 16 now. So time flies. So that's the first thing. The second thing, before I run into other issues, is I truly believe in your organization. That's why I come back. But I also would like to emphasize that your organization does many important things, and some of your members do really very important things. And I'd like to highlight Leah's contribution over the past few years. In particular, I am a chair of a research committee, the third largest funding research group in Canada. And a few years ago, so we give out, about $1 million a year in arthritis research. And a few years ago, we thought, here we are, just a bunch of scientists. What do we really know about arthritis? And we decided to invite some patients to be patient advocates on a research review committee. And Leah has now been reviewing for us at least 3-4 years.
This will be my fourth year.
4 years. And so those are amazing contributions that really make the science move forward. And I really believe in my science, so I appreciate the servant contribution. That's the second thing. The third thing, so before I speak about that, I can talk to you a little bit about MI4. We'd like to call ourselves MI4, so it's the McGill Interdisciplinary Initiative in Infection and Immunity. And it's we started to work together in 2018, so we're going into our 4th year. McGill is very well known for neurosciences, and some of you may have heard the name Wilder Penfield and all of the amazing things that he did at the MNI. After the neurosciences, I think McGill is also very well known around the world for genomics, and I like to think that my brother had a little bit to do with that. So the reputation is excellent there. And McGill is also very well known around the world in cancer. So here you have three leading types of research programs at McGill. And about 5 years ago, McGill asked, give us your best projects. In which direction shall we now go? We do neuroscience, we do genetics, we do cancer. So where are we going to go? So a group of us together decided it's time that we raise the profile of McGill at the level of infection and immunity. We have a lot of great scientists, but our scientists are all spread up out everywhere. So if we come together, maybe we can sort of move the agenda forward. And so in the last 4 years, we've already raised over $30 million that we've allocated to different projects in infection and immunity. You can imagine that a lot of this has gone to COVID research because that has been the sujet du jour. But I wanted to highlight in particular one project that we funded, and I will mention it at the end, where we're particularly interested in moving the agenda forward in understanding lung disease and rheumatic diseases. So those are some of the exciting things that are happening at McGill, and I'm happy to be a part of this evolving science. So that's just by way of introduction. So now, as mentioned, I'm a rheumatologist, but I see an awful lot of patients with lung disease. So many of you will be familiar with, of course, this is an arthritis group, so you're familiar enough with the joint disease. Maybe one of the things that you know less is that a lot of people with joint disease have many other organs that can be involved as part of their arthritis, and the lungs being one of the most prominent organ that can be involved in people with arthritis. So I thought that it was maybe relevant to bring you some new knowledge about something that you may not hear very often about. So,
recording in progress.
Okay. So usually when we do scientific presentations, we have to do disclosures. So I do a lot of research. I do have funds from pharmaceutical companies to do some of my research. But I'd like to think that I'm generally very unbiased as much as I can be, and I don't think that my funding will have any impact on my presentation tonight. So I have 3 objectives. I'd like to cover 3 subjects. I want to describe to you what the spectrum of lung disease is in people with rheumatic diseases. I want to make you familiar with this new concept of multidisciplinary teams and the importance of working as a group and not just as a rheumatologist in isolation. And then we can discuss some of the treatments that we're using to treat the lung disease and rheumatic diseases. So before I start, you probably have seen pictures of joints many, many times when Dr. Starr presents, when Dr. Fitzgerald presents, and so on. And then I thought you probably haven't seen lungs, before. So I thought I'm just going to give you a little refresher on, what do the lungs do and what do they look like. And really, so this is a picture here of somebody, a normal lung tissue. So there's 3 components to the lungs. There's the airways. That's what brings the air in and lets the carbon dioxide out. So there's the airways. There's the circulation, because once the oxygen is in, that oxygen has to move into the circulation to go to the heart. And at the same time, the carbon monoxide has to move out from the circulation into the airways. So there's the airways, there's the circulation. So here you can see some airways. The little red dots, I'm not sure if you can see them well, that's the circulation. But those don't just hang there as airways and circulation. The third component of the lungs is the tissue that supports, that holds together the airways and the circulation. And that's what we call the interstitium. And so we're going to talk about interstitial lung disease. It's that component of the lungs, so not the airways, not the circulation, but the interstitial tissue that supports the lung that is affected in these diseases. And the reason why I put up, this is a normal chest x-ray up here, and normally our lungs are full of air, right? And in a healthy lung, and air is transparent in a sense, so that's why a healthy lung looks black. There's no tissue to pick up the radiation, okay? So in a normal, healthy lung, the air sacs are very, very small. The circulation is very, very small, tiny, microscopic. The interstitium is microscopic, and really the lungs is essentially made up of air in these structures. Okay, and we expect this to be very dark. And of course, just to finish off the picture, so this is the heart, but so we're talking about the lungs. So to go back on the same concept, so this is your trachea or your windpipe where the air comes in. The trachea will divide into different pipes that we call bronchi, and the bronchi are eventually going to break down into very, very, very small airways that we call bronchioles. And at the end of the bronchioles, which are still the airways, you have these sacs of air that we call alveoli. So all of this, from the trachea to the bronchi to the bronchioles to the alveoli, those are the airways. So the air circulates in those passages. Around the alveoli is the circulation that I just mentioned. So these blood vessels, the blue vessels are venous blood. They bring carbon dioxide so that we can expire it. And the red vessels here are the blood vessels that have absorbed oxygen, so they are oxygenated, okay? And then, so here in another view, this is an alveoli that's full of air. You have oxygen going in, carbon dioxide going out. So the airways, the circulation, and in between there, you have this tiny layer of interstitium to sort of hold the two structures together, okay? So, and that's where this tiny layer of interstitium has to be very, very, very small, because otherwise it's going to interfere with the air coming out and coming in and the carbon dioxide going out. Okay, so it's a tiny, tiny, small structure just to hold the airways and the circulation together. Okay, so now I'm going to come. So again, just to emphasize, because there are three main structures in the lungs, there are three main types of diseases that can affect the lungs. There are the diseases that affect the airways, and that will be diseases like COPD, some of you may have heard of that, bronchitis, emphysema. Those are diseases of airways. That's not what we're talking tonight about. There's the circulation, so there can be diseases of the circulation, and some people might have heard of pulmonary hypertension. So pulmonary hypertension is a disease of the circulation. That's not what we're talking about tonight. The third structure, as I mentioned, is this very important structured interstitium. That's what we're talking about. If the interstitial tissue becomes thickened, becomes scarred, then you're going to develop interstitial lung disease. Okay? So again, just so now I'm slowly getting to the topic that we're interested in, which is interstitial lung disease. But I want to emphasize that this is not the same as COPD, which is a more common type of lung disease, especially in older people, especially in people who have smoked. So these chronic obstructive pulmonary disease is a disease of airways, where this is a normal bronchiole, but you can see if the bronchiole, the airway becomes very, very narrow, that's going to cause a problem with respiration. Or if the alveoli become destroyed, again, you have less tissue to allow for air exchange. And so the airways are impaired, and these people have difficulty breathing. So that's not, that's really diseases that belong to the respirologist. But in interstitial lung disease, here, as I said, you have the airways. The red dots are the blood vessels, but this interstitial tissue, which is supposed to be tiny, 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 tiny to allow exchange between the airways and the circulation, this tissue becomes very, very thick. And very, with lots of scarring, and so it distorts the airways, and it interferes very much with gas exchange, with the exchange of oxygen and carbon monoxide. So that is what we're talking about. So disease of the interstitial tissue of the lungs. Okay. So, having said all of that about interstitial lung disease, in medicine it's never that simple. In life it's probably never that simple. There is no such thing as one interstitial lung disease. There are many, many kinds of interstitial lung disease, and some respirologists will specialize only in all of this variety of interstitial lung disease. But among the variety of interstitial lung disease, there's one in particular that we call connective tissue disease, interstitial lung disease. In other words, what this means is lung disease in people with autoimmune diseases. So that's where, in this circle, that's where a rheumatologist lives when they're interested in lung disease, in autoimmune disease, okay? So these are going to be the sorts of patients that I'm going to see and that I'm going to describe to you. Why am I interested in interstitial lung disease? I'm interested in interstitial lung disease in my patients with autoimmune diseases because my patients are really sick and I want to try to do something about it. How are people with interstitial lung disease sick? There are two main symptoms. There are many symptoms associated with interstitial lung disease, but the two main symptoms are coughing and shortness of breath. And you can imagine that if you already have lots of arthritis, because this is a problem among people who already have arthritis, who already have lots of problems mobilizing and so on from their joints, and if now they're coughing all day, and if they're short of breath and they can't walk more than 100 or 150 meters, it really compounds their problems. So there's a real urgency to try to limit the extent of the lung disease in these patients because they have enough other problems to deal with already. Okay, so these are the most common problems are the coughing and the shortness of breath. And then the other thing really that I worry about, and I don't expect you to read this graph, but what this shows is that if you have arthritis with lung disease, your risk of death is much higher than if you don't have the lung disease. So often you will hear, most of you probably have a rheumatologist, you will hear the expression, your arthritis won't kill you. Well, that's not exactly true, because some people with arthritis with complications such as lung disease, it will, okay? So arthritis is a serious thing, and especially when it starts to affect some of the visceral organs. So this is something that's really serious that has to be taken serious. So that's my preamble. So what about this connective tissue disease, interstitial lung disease, or the lung disease we see in autoimmune disease? And that's what I'm gonna talk about for a little while now. So I thought that I'd start by presenting you two real cases. I like to show, some pictures are worth 1,000 words. So this was a very nice 78-year-old man who's had rheumatoid arthritis for a long time. I'd say at this time he had had it for at least 10 or 15 years. He has an antibody that's very closely associated to rheumatoid arthritis that we call a CCP. If any of you have rheumatoid, you will be familiar with that. And so in 2019, he started to say, I feel a little bit short of breath, but he's 78. Well, at that time he was 76, and maybe he was a little less active and so on, but nonetheless, his rheumatologist said, okay, let's have a look at what's happening in your lungs. And when they did a CT of his lungs, lo and behold, I told you that healthy lungs should be black. So this part of the lungs here is black. That's normal, it's full of air. But what's all this white stuff here, there's a little bit there. You're not supposed to see that. So that's scarring of the lungs. So already in 2019, his shortness of breath was probably from the beginnings of interstitial lung disease, most likely related to his rheumatoid arthritis. And the other thing that we do for patients is we look at images, but we also measure the function of the lungs. And the way we measure the function of the lungs is we do pulmonary function tests. Some of you may have had those, where you blow in a machine and you can measure how well the lung functions. And in 2019, his lung function was almost normal. You would say this is for a 78-year-old man. In fact, his lung function was normal. So he's a little bit short of breath. He doesn't have a lot of scarring. His lung function is normal. Let's not do anything about it right now. Let's not rock the boat. So over the next 2 years, he starts to develop more and more shortness of breath. And then the scan is repeated, and his scan has progressed tremendously. So this is the same person 2 years later, and you can see what was a little bit of scarring down there is now affecting huge chunks of his lungs. And not only that, but his pulmonary function test now is about 50% of what it should be. So he's lost 50% of his pulmonary capacity. So this is serious, okay? And what's interesting, if I might add, is that while this was progressing, his joints were very well controlled. So that you can have well-controlled arthritis, and yet the pulmonary disease can have a life of its own. So that's one type of patient that we see fairly commonly. And then this is another woman that I saw late last year, a 71-year-old woman, and I have a particular interest in a disease called scleroderma, so I get referred a lot of patients who develop scleroderma. She had clear-cut scleroderma when I looked at her skin. She also had antibodies that are highly associated with scleroderma. And in scleroderma, I really worry about the lungs. And somebody comes in my office, I say you have scleroderma, they go straight to the CT scan. Okay, I need to know what their lungs look like. And in fact, at disease onset, okay, she had barely a few months of disease, you can see how much scarring already she has in her lungs. So there's a certain urgency to do something for this particular person. And again, at disease onset, she had less than 50% of her lung capacity. Okay, so this is really a serious problem in people who otherwise, would have arthritis. So just to take a step back, so I talked about interstitial lung disease. There's different kinds of interstitial lung disease, some that are principally affecting just the lung, and that tends to be attended to by respirologists. But then among people with autoimmune diseases, you can have that subset, and that's what I'm interested in. And then all of these different diseases, so rheumatoid arthritis, scleroderma, people with myositis, people with Sjogren's disease, people with lupus, subsets of these patients will develop interstitial lung disease. And then there's another layer of complexity, because there's not just one type of connective tissue lung disease. There's many different types. Here I've listed 5 of them, and we find that we're now into this alphabet soup of connective tissue diseases, and I'll tell you what these letters mean in a second. So if you, often when I talk about autoimmune disease, I put things in perspective. So, people with rheumatoid arthritis and with Sjogren's, we say it's about 1 person out of 100 in the general population. So about 1% of people in the general population will have rheumatoid arthritis. And then it goes down by a factor of 10. So 1 in 1,000 people will have lupus, 1 in 10,000 people will have scleroderma, and 1 in 100,000 people will have myositis. So these are, rheumatoid is not common, but 1% of the population is still a sizable number of people. But when you come to lupus, and especially scleroderma and myositis, these are rare diseases. Ça court pas les rues, okay? But having said that, when you look at the proportion of these people with lung disease is fairly rare in rheumatoid arthritis. So somewhere about only 5% of people will get lung disease. Whereas, as I mentioned, in scleroderma, well over 50% of my patients. So when I see a scleroderma patient, I think of the lung right away. Whereas when I see a rheumatoid arthritis patient, it's not that common, okay? And again, when I see a myositis patient, some of my patients, again, they go straight to the CT scan because the lung disease can be quite severe in these patients. And then, to make matters worse, different types of involvement of the lung tend to associate more with certain diseases, and I'll show you what these types are. Okay. So there's 5 main subtypes of lung disease that you see in people with connective tissue disease. The first one is called NSIP, so non-specific interstitial pneumonia. What we see here is just this general whiteness. It's called ground glass, and what we think it shows is it shows a lot of inflammation. So we tend to think that NSIP is an inflammatory disease. So that's important to realize that, because it's going to tell us what kind of treatments we should be using in these patients. In UIP, so usual interstitial pneumonia, here it's much more scarring. And in fact, the radiologists, the terms that they will take to describe this is actually, they have honeycombing. It's like a honeycomb, and it just describes a lot of scarring. Not a lot of inflammation, a lot of scarring. So here I'm going to tend to want to use an anti-inflammatory, and here I'm going to tend to want to use an antifibrotic. So depending on the subtype of lung disease, that's going to direct my treatment. In Sjogren's, there's an entity that we call lymphocytic interstitial pneumonia, so we often say LIP. And what's really characteristic of LIP is they get these huge holes in their lungs. We call them cysts. Okay? So and why do they have that? I don't know, but that's one of the ways that we recognize that somebody might have Sjogren's affecting their lungs. Then there's this entity, this is more common in myositis, it's called organizing pneumonia, and it just looks like pneumonia on the x-ray, okay? And this can wax and wane, and of all the different types of subtypes of lung disease, this is the one that I think is most responsive to treatment. So when I have, and today I got a call from the Lakeshore, somebody said, we just have a patient here who's got arthritis and organizing pneumonia on their scan. Will you see them? And I say, of course, I'll see them tomorrow. He's coming tomorrow at 1. And I feel good that I think I'm going to be able to do something about his particular lung disease, because this tends to be responsive to treatment. And then the last subtype, and this we tend to see mostly in lupus, is called bronchiolitis obliterans. So what it means is the very terminal bronchi, the small terminal airways, are so fibrosed that they are obliterated. So there's a complete disconnect between the windpipe and the bronchi and the circulation, because there's just that connection is not there because the bronchioles have been obliterated. So this can be quite severe. So that's the sort of crash course in interstitial lung disease, okay? So I hope I've made it very complicated, because the reality is it is, and it's not just complicated for you, it's complicated for us as physicians. And so one of the things that we've innovated in the last 7 to 10 years in looking at these diseases is we don't look at them in isolation. As I said, I'm just a rheumatologist. I need other people to help me sort of interpret all of this information. And the new standard of care for treating these patients is what we call the multidisciplinary team. So there's a whole team of people. We see the patients as a group, okay? And so in fact, and it's more than 10 years, because in fact in 2002, the large American and European Respiratory Society said, oh, that's okay. You have to start to look at, evaluate these patients as a team and use the role of the multidisciplinary team. And the MDT has now become the gold standard for the diagnosis of this. Okay, so this is sort of a picture. So here again, I'm going to show you another case and show you how we work the multidisciplinary team. So this is a patient I saw last year. He was a very young man, 48 years old, a school teacher, in otherwise very good health. And I remember on history, in fact, the reason why I put that is he's very athletic, runs a lot, okay, very, very healthy man. He got COVID early in 2021 from his children, he thinks, but his COVID at that time was manifested only with headaches and fever. He didn't have any lung involvement at the time that he had the COVID, and he recovered from the COVID. His past medical history, he had a little bit of reflux and he had a little bit of hypertension, really unrelated comorbidities. And he was taking Pantlock and a medication for his blood pressure. And when he came, he said several weeks to several months after having had COVID, he started to have increasing shortness of breath, couldn't go for his usual walk, couldn't even walk upstairs for a runner. There's something definitely wrong. So he presented to his family doctor, and his family doctor said, okay, let's do a scan. And the scan was abnormal, but not typical of anything. So there's definitely some interstitial lung disease. You can appreciate that because there's way too much white streaks in this lung. You would want it to be much blacker. But it didn't have this classical picture of what I showed you, NSIP, UIP, organizing pneumonia. It was very nonspecific. So yes, he's got some lung disease, but we can't really, from the scan, say what type of lung disease. So then we do some pulmonary function tests, and these are very abnormal. Again, has only about 50% of his lung capacity in a 48-year-old man. So he's really in trouble at this point. And then the next thing is to try to find the cause of this. And often what physicians, and mostly at this point it was still respirologists, rheumatology was not involved, they send off a whole bunch of autoantibodies looking for autoimmune disease. And lo and behold, he's got too many antibodies. And that's where the respirologist sort of calls up the rheumatologist and says, you're going to have to help me interpret all these serologies, okay? Because some of his antibodies were suggesting maybe myositis. This could suggest rheumatoid arthritis. This antibody could suggest vasculitis. This is an antibody we see in scleroderma. This we see in lupus, and again, 2 other antibodies that you see in myositis. And the respirologist says, I don't know how to interpret this, we need to put our heads together. So, when I, after having said that, and I'm going to save you the the problem of having to try to answer the question, but what could this be? This could be rheumatoid lung because he's got some antibodies relating to that. It could be scleroderma lung. He's got antibodies related to that. I mentioned the myositis antibody. Could it be COVID? Is this a new entity? Maybe he didn't have lung disease at the onset of the COVID, but is this something that can happen subsequently? And we're still learning so much about COVID. Whoops. And then could it be some other diseases that affect only the lungs, things like sarcoid or hypersensitivity pneumonitis, but you wouldn't expect to see antibodies. And the reality is, at this point, any one of us working in isolation could conclude that it could be any of these. Okay, so on n'est pas plus avancé. We have to move on. So that's why we have now started to use this multidisciplinary approach, and we work mostly with respirologists and rheumatologists, where we can look at these difficult cases from different perspectives and try to come to some sort of meaningful conclusion, because that's what's going to help us decide how we're going to treat this patient. So what do the respirologists do? They look for signs and symptoms of lung disease. They look for occupational exposures. Smoking is often an important risk factor in these things. They often look at the scans, but in his case, the scan was not very, well, it was abnormal, but it wasn't classical of anything. They look at pulmonary function tests to sort of measure severity of the disease. Sometimes they do a bronchoscopy, and with the fluid that they get on bronchoscopy, they can see if it's inflammatory or not. And sometimes in these patients, you basically have to go to lung biopsy to try to make a diagnosis. And on the other hand, we rheumatologists, we look at things from another point of view. We ask ourselves, could this patient have an autoimmune disease? And so I have all sorts of clues that I look at. I ask patients if they have Raynaud's disease. So Raynaud's is a common symptom in people with autoimmune diseases. We do things like capillaroscopy, or we look at nail folds, again looking for different clues. Different lab tests, often looking for myositis, and of course the serologies, which are the antibodies that can sometimes be help us make a diagnosis. And then of course we need a radiologist, we need a pathologist when we go to lung biopsy, and sometimes we even need geneticists to help us put these cases together. So when the large respiratory societies came out with the statement in 2002, they said we really need, what they meant here were respirologists, radiologists, and pathologists. But I think that in our institution, if anything, we've moved this a little bit further to include in the multidisciplinary team the rheumatologists, who can really make big contributions in terms of trying to make a proper diagnosis and determine the right treatment. So we have at the Jewish, we have lung clinic every last Monday of every month. We sit there. We're actually myself a rheumatologist, a pulmonologist, a cardiologist, and we review every single one of these difficult cases together to make to try to make a better diagnosis. So this is sort of the new way of approaching this really complicated entity, which is interstitial lung disease. Okay, and then for the third part, or in the last part here, I thought I would touch briefly just on treatment. So what are the treatments that are what are the treatments that we offer these patients? So I've mentioned a lot that some of the subtypes are more inflammatory and some of the subtypes are more fibrotic. So depending on where the person is on that spectrum, we're going to choose different treatments. So in the anti-inflammatory treatments, we use medications such as, and some of you may have heard of these medications, cyclophosphamide, mycophenolate, tocilizumab, which is Actemra, and rituximab. And it makes sense to be using these drugs because, in fact, these are drugs that are approved to treat arthritis. And we think that the inflammation in the joints is similar to the inflammation in the lungs. So if we're treating the joints, hopefully we're also treating the lungs. While we only have, and it's only been over the last 4 years or so, that new antifibrotics have come on the market, and the one that's been around the longest is called nintedanib, or OFEV. And then recently, about 2 weeks ago, there was a new study in rheumatoid arthritis lung disease that showed that this drug pirfenidone seems to be an effective antifibrotic in rheumatoid. So these are limited treatment options, but at least there are some treatment options, and I'm just going to skip this. But so they're still limited. Why? Because at best these medications will slow down the disease course. Whatever's been damaged, we don't have treatments to repair the damage or to reverse the fibrosis, okay? So there's a certain urgency to try to treat patients before the damage accrues. And so therefore, and that's another optimistic thing, is there's still a lot of research trying to find newer and better treatments for these interstitial lung disease. Lots of research looking at anti-inflammatory drugs, and lots of new research looking at novel anti-fibrotic drugs. So the future is, in a sense, bright. We're not there yet, but at least there's lots of research, and hopefully that will lead to better treatments. So the treatment field is evolving, but then as we get newer, better drugs, there are always more questions that are added, And one of the more important questions is, when do you start patients' treatment? If the patient has 50% of their lung capacity, they have no reserve, it's obvious that we're going to start treatment. But the first patient that I showed you, where initially his lung disease was preserved, we don't know if we should be starting, when we should be starting treatment in these patients, especially that not everybody progresses, and we don't know how to predict who's going to progress. So treatments are really much more difficult in people with, treatment decisions are more difficult in people with milder disease, and we need biomarkers of disease progression. So when I spoke to Leah and we decided that I would be speaking about this tonight, she said, maybe you can slip in a word about your own research. So this is where research comes in. When we have important questions like this and no answers, that's where we undertake some research projects. So I'm just going to highlight 3 research projects that I've been involved with in the last couple of years. So this is my postdoctoral fellow, Sabrina Hoa, who is a brilliant fellow, and she's now a rheumatologist at the SHIM. And when she started her postdoctoral fellowship, the question was, should we be treating patients earlier? Because as I said, the drugs don't reverse the damage. So if you wait and wait and wait and the damage evolves, you can only prevent further damage, but could you have preserved some lung function if you had started treatment earlier? So she actually looked at this question, and I'll show you on the next slide the results, but for her project, this was named in 2019 one of the top 10 research advances by the Arthritis Society in Canada. So what she did is she took the data from the Canadian Scleroderma Research Group, which is a large Canadian cohort that I have led over many, many years, and we've accumulated a lot of data on a lot of patients with lung disease. And she clearly showed that if you started treatment in people with mild disease, who typically would not have been treated, if you started it early and you looked 2 years later, those who started treatment had 10% better lung function than those who didn't. Okay, so this was probably one of the first times that we could really show that we were waiting too late to treat our patients. If they have moderate disease, and especially if they have severe disease, they're stuck, so might as well try to treat them earlier. Okay, and so that's what this project was able to show. Then now what she's, and the same postdoctoral fellow who's now at the SHIM is interested in trying to say who's going to progress, because not everybody progressed. So she's going to use the same data from the Canadian Scleroderma Research Group, and on all these patients we've saved some blood samples. All these blood samples, we have thousands and thousands of blood samples dating back since 2004, sitting in Calgary. So she's going to look back, and she's going to say, among those who progressed, comparing to those who didn't, what's different in her blood? And she's going to do really sophisticated, what we call proteomics analysis, and we're just in the process of doing, we've just gotten some funding to do that, and we're selecting the samples with the idea that then it's not only that we should treat earlier, but we're going to know who we should treat earlier, because maybe some people are mild and will stay mild, so maybe they don't need treatment. We need to treat early those who we have markers that they're the ones who are going to progress. So these are 2 projects in the disease of scleroderma. And then the third project, which is the project that I mentioned at the beginning for MI4, so we've decided scleroderma is a rare disease, and it's an important disease, and it's close to my heart. That's where I've spent most of my research. But It's still a rare disease. Could we expand this research program to include less rare diseases and more diseases? So the FibreNet project, we're looking across all rheumatic diseases. So we're including patients with rheumatoid, we're including patients with myositis, and we're also including patients post-COVID lung. And the reason why we're including patients with post-COVID lung disease is that the amazing thing with COVID, and I've seen a lot of patients get into trouble with their lungs from COVID, it's reversible. You do the lung scan when they're really, really sick, it looks very fibrotic, and then you repeat the scan 6 months later and all the fibrosis is gone. So there must be mechanisms of resolution, okay? We know that, that's the proof, our body can heal itself. So what's wrong with the mechanisms of resolution in non-COVID diseases, in scleroderma and myositis? And if we can uncover mechanisms of resolution, then we go after the question of reversibility, not just preventing further damage, but actually reversing damaged lungs. So that's the whole idea behind FibreNet, and really the research is really very, very exciting, and I'm hopeful that over the next few years we will make some substantial contributions there. So basically, I come to the end of my talk, and I go back to my title, and I called it a day in the life of a rheumatologist, and I was going to ask, does anybody recognize what this is? It was very much in the news last year. This is the rover that NASA put on Mars sometimes last year, and that rover was called Perseverance. So this is what my life, my day-to-day life as a rheumatologist is. I am searching in the dark, I'm discovering new things, I'm on Mars, I'm in my rover, and I have to persevere, and that's the only way that we're going to be able to make any progress in these diseases. So basically that's what the day of a rheumatologist is like. So that's it. So thank you very much for having listened to me, and I'm happy to take some questions. Leah.
I have a question, which I find this really interesting. As a person who's lived with RA since childhood, so it's many, many years, I find it interesting because there are so many things I'm aware of. I'm aware of the chance of heart disease in a female with rheumatoid arthritis. I'm aware of kidney problems. I'm aware of, I know that apparently it was my rheumatoid arthritis. It was an autoimmune reaction that killed my thyroid. Why in all these years have I never heard about the possibility of lung disease? And is this something I should be concerned about? Should I be asking my rheumatologist to look into this? It's just like, it's really surprising because I also do have some medical training because I'm part of the patient partners course at McGill Medical School. And this is the first time I've heard of it.
So I'll tell you that this is an emerging field, especially for rheumatoid. We've known about this in scleroderma, we've known about this in myositis for many years. But people are finally starting to pay attention in rheumatoid. We knew it was there, but we really didn't look very much for it because we didn't have very good treatments. So, you're going to tell a patient, and the other thing with the rheumatoids is they don't necessarily progress as fast. So rheumatologists would tend to try to not see that. But now that there are new treatments, there's really an urgency to try to discover or to uncover this in our various patients. And now I'm starting to, to talk about my patients, and it's important to ask our patients if they're short of breath and if they're coughing, and we have low thresholds to investigate them. And we at McGill, and in particular at the MUHC, just recruited a young rheumatologist who is doing only lung disease because it's such an emerging field, and because we as rheumatologists realize that for many years we've been neglecting this, and there's, we need to do better. So yeah, it's an emerging thing. Yes.
What about when you have allergies? It's what happened to me personally, 2001. And also stress, they were telling me. But it took them a long time. They said, oh, I had water in my lungs. And they weren't too sure. And they started debating, and then finally, they put this nuclear liquid, and then they said, there was something wrong. And they drained the lungs.
Uh-huh.
And it took a long time before before it ended. But that's the only thing they were saying. What saved me was I have a good heart.
Mm-hmm.
And it's strong. And I was up 3 times, I cheated death. Pneumonia, aneurysm, and then it was surgery on my what do you call it, disc arthritis. They had to fuse a few discs, and again, it took a long time before, but thank God the surgeons were top notch.
So it's hard for me to, so without a scan, without
I know,
function
I know.
test, without,
But
it's hard for me to.
they won't, right now, the first of last year, I fell down and fractured my leg. And I was in the hospital for about four or 5 weeks. The rehab, I wanted to go to Captain Moon. And when it was private, I was there 10 years ago, it was perfect. And once the government took over, it was a complete disaster. And that's why I waited. And then I had to wait to get rehab with the leg shoulder. And again, the doctors didn't even talk to each other.
So there we go back to the story of multidisciplinary clinics. There's
You know?
priceless to have a multidisciplinary team. Paulette.
As you know, I'm someone who's been involved with AWISH indirectly since 1992 and more so since 1997. We've lost 3 of our clients, 2 with RA, and 1 with scleroderma, of lung disease. And of all the guest speakers we've had over the years, I don't think research has begun as to why some did die from the lung disease and what the cause really was. This is a fantastic presentation tonight, and I'm very thankful that someone is looking into it because it is a terrible way of dying, and these people were very young.
And on that note, I'll tell you, yesterday, Lung Clinic was on Monday this week. Yesterday, that was yesterday, or Monday. One of our young scleroderma patients just came back from lung transplant. So in some patients, we now do lung transplant. She looked wonderful. But in the we haven't been doing a lot of lung transplants for scleroderma. So that's too is evolving. But we need better treatments to so that there has to be something better than lung transplant.
Well, the person that we lost that had scleroderma had a lung transplant.
Even really.
And at first they said no because she was young and they just didn't want to do it. And then they realized, well, she has children. And then they agreed to do the transplant. And she lived about 20 years
Wow.
after her transplant, but she died of
Progressive lung
disease.
disease. But it bought her another 20 years.
Yeah, thank you very much. I find it very fascinating. I've got both lung disease and rheumatoid arthritis, so I'm glad some research is being done in the field.
Oh yeah,
It's
lots of
probably
research.
nothing time for me, but anyway, you're working on it. I'm very happy.
We are.
Yeah,
And
thank
often
you.
when I recruit patients into research projects who have the disease, I often tell them, you're right, being a patient in research, it has to be altruism because it's probably not going to help you, but it's going to help the
Yes,
the
well,
next
that's it,
generation.
yeah.
So that's why we try to do this.
Thank you.
Any other questions? Yes.
Can you tell me what myositis is?
Yep. Okay. So myositis is another thing that I'm very interested in. So myositis is inflammation of the muscles, and so there are. Again, I could show you a similar picture. There's not just one kind of myositis. There's probably 4 big families, and within those 4 families, there's another 10 different entities. And so what's relevant to a group like this is that there are subsets of patients with myositis that we call dermatomyositis, so you may have heard that name, and those patients will sometimes, and again I saw a new dermatomyositis in my clinic today, they actually present with arthritis. And then they tell their doctor, I'm having inflamed joints, and then the doctor notices that they have a rash, and then when you examine them, you realize that they're weak. So a subset of patients with inflamed muscles will actually present with joint diseases. And then among those patients, they tend to have interstitial lung disease is very common, and it can be very severe. And I tend to lose sleep over patients like that. So when I have a patient like the one I saw today, I have to be really on top of her, because what's gonna be very damaging for her is not so much the skin, not so much the joints, not so much the muscle. It's gonna be the lungs that are going to be a problem for her.
Is there such a thing as lung exercise?
Oh, yes, actually. So there is, and so one of my very best friends does, it's called pulmonary rehab. And so, yeah, you raise an excellent point, because us doctors, we like to prescribe pills, so that's why we talk about medications. But in some patients, when the medications don't work, they have to learn how to manage their lung disease, and we send them to pulmonary rehab. And there's a huge project right now that my friend is coordinating across the province, because it's one thing for patients with respiratory diseases to come to the Jewish. It's hard, and the patients are breathless from their lung disease. So they're trying to do pulmonary rehab through virtual communications. So, and she's sort of leading this huge endeavor to bring pulmonary rehab out to the community using video conferencing. Yeah.
Is it on Google?
No, you actually need to be part of a pulmonary rehab clinic. You have a real doctor, you have a real nurse, so it's not something that you do on your own. It's really a medical therapy through the form of exercise for the lungs.
I actually went through the pulmonary rehab via Zoom.
Exactly. Okay.
And it was 8 weeks, I think it was.
Yeah.
And it was wonderful.
Yeah.
It really was very encouraging to do the exercise, and I'm still doing it.
Okay.
And this is about two years ago.
Yeah. So that's.
So it's wonderful.
Yeah.
It's really very, very good.
You have to be very motivated
Oh,
too, though,
you do.
because it's heavy duty training, and then the most important thing, as you say, is to continue after that. So, but the patients who have that motivation, it can make a big difference. Yeah.
But also they claim that meditation,
Mm-hmm.
a breathing in and out.
So I think through pulmonary rehab, they teach you how to breathe.
Breathe, right.
They reteach you how to breathe, because we all know how to breathe, right? But they teach you how to breathe in the context of some pulmonary restriction.
And also another thing with taking Tai Chi,
Mm-hmm.
they keep on saying, we don't know how to breathe.
Yeah.
And some breathe through the nose, some through the mouth.
Yeah.
But with both a combination, but it's stress. Again, going back, it's stress. This is what they keep telling us.
Just to add one more, there's in the United States, there's a person called Noah Greenspan or Green whatever,
Okay.
and he does pulmonary rehab for free
Okay.
on the internet.
Okay.
So just researchers. He's in New York City, I think.
Okay.
But it's very good. He has good company. And also doctors.
As a general comment, you are a very dedicated scientist, obviously very much involved in the subject. Is it frustrating for you that there's no cure for this disease, or is it challenging?
It's very frustrating.
Okay.
Okay, and so I work for Cure. That's my end goal. I'm not going to get it in my generation, but I hope to advance the science so that the next generation of scientists are going to be able to get to that. That's the ultimate goal. Yeah.
As a patient, it takes us forever and ever and ever to get an appointment to see a specialist such as yourself. How on earth do you get all these specialists together at one time to form a team?
I'm good at twisting arms. I can be very convincing, trust me.
No, but it's upsetting in that as you know, it takes forever and ever. And
Yeah.
then when
But you know, this is the new way of doing things. You know, I do many other projects. I work with oncologists, a whole different set of projects. And the oncologists have understood the concept of multidisciplinary team a long time ago. And the oncologists, that is their model of care, to work as a team. And I think it's a fabulous model that we are finally, among other specialists, so here rheumatologists, respirologists, and others, are finally understanding the benefits to the patient of the multidisciplinary team. And the oncologists, once again, have led the field, I think, in making us understand how important that is.
Because we listen to the show on Sundays with the Gill Foundation, and a few times now the doctors that they've had on doing research have noticed that they keep referring to, it's not just me, but a team
Yeah,
that's working.
absolutely.
Maybe it is.
Yeah.
But are we going to hear you on that show sometime?
I hope, once I find a cure. Okay, thank you very much.
Well, I would like to thank Dr. Hudson
Thank you so much.
for a
That was
very
beautiful.
informative and excellent talk. Thank you very much.
Thank you so much.
You're welcome.